sometimes the blood vessels from the aorta to the kidneys or the bowel will get partially blocked. I read
Yes.
something about a nutcracker where the vein from the kidney is in the wrong. And I think my cadaver as a medical student had a nutcracker because it screwed up my understanding of anatomy because the vein was in the wrong place in my cadaver. Ethel had an anomalous blood vessel to her kidney. But just in general, just kind of briefly, if the how would one know or find out that you're getting poor blood flow to your bowels or your kidneys?
Well, one of the more frequent situations that we see. Now let me say from the outset that the blockages we're talking about can occur in any of the peripheral arterial beds that you have. So arteries going to your intestine, arteries going to your kidney, arteries going to the lower extremities, arteries going to your pelvic organs, etc. They can all harbor these blockages. And
Ah,
if you have a significant blockage, let's just say you have a significant blockage to an artery or within an artery that's going to the kidney, and that kidney's not getting enough blood flow, then one of the ways that you might find that out would be through your family physician who says, hey, your kidney function is off a little bit on our routine testing that we did, and we're going to look into that a little more with probably an ultrasound examination.
okay.
And then on the ultrasound, lo and behold, a blockage shows up. So when I was in training, we did all those operations open with a bypass. We very quickly transitioned in the late 1990s to fixing a lot of those blockages with balloon angioplasty with a stent, usually, unless it was something rare. But almost always we would leave a stent behind. And we did that for an awful lot of patients. And the thinking was we know that that artery is intimately involved in the control of blood pressure. And so we can better control blood pressure if we don't have a blockage in the kidney artery. And we can keep those patients from going on to develop renal failure.
Yeah.
Now, there are several studies that were done, controversial, but certainly a lot of people use those studies. And one was the Coral study, and I can't remember the name of the other study offhand, but they both came out at the same time. They're about 10 years old now, and they radically changed the face of how we treat blockages in the kidney arteries. And it turns out, and I do believe this is very controversial, but I believe that we were way too aggressive in treating a lot of the kidney
Huh.
lesions. And so we don't treat near the number of kidney, or we call them renal artery stenosis, RAS. We don't treat near the number that we used to because we were probably over treating a lot. And it turns out that a lot of those can be treated medically, especially with our new uh, medications to control blood pressure, the so-called ACE inhibitors and the so-called ARBs is another big
Gotcha.
class. So, but we do still treat a lot of blockages that go to the intestines.
Yes, tell me about that.
That usually is presents in patients who are very avid smokers. They've lost a lot of weight recently, and they have abdominal pain after they eat. So, going back to that whole discussion we had about claudication, when you exercise the muscle group and it doesn't get enough oxygen delivered to it because of a fixed problem in the artery, you can develop a cramp. Well, the same thing can happen in the intestine.
You get a
You,
claudication of your guts. Unbelievable.
yes,
That
it's
makes
called.
sense.
It's actually called postprandial
After you eat.
claudication. Yeah, postprandial abdominal pain, postprandial
Wow.
angina.
So you diagnose that. So what can you do about that?
We can actually, once we define where it is, we almost always use stents to correct that problem. And again, a stent is a metal scaffolding that we're going to use to push that blockage to the side to reestablish a good flow channel there.
And it's effective and it works.
Very, very effective, and
Tremendous.
risk profile very low, and way better than some of the other things that we still do sometimes, but rarely,
Uh-huh.
which is where we go in with an open operation and we do a bypass of an intestinal artery or a clean out of an intestinal artery or remove some acute problem like a blood clot in an intestinal artery. And let me also, while we're talking about that,
Please.
and we're talking and kind of getting back to the blood clot, I meant to say this earlier and I didn't. COVID, as you
Yes.
probably know, is a virus which is very substantially correlated, or I should say maybe strongly correlated with the inducement of blood clots.
Yes.
And it's
Fibers,
not
really
just
bad blood clots.
yeah, and not just lower extremity deep vein blood clots, but we see blood clots in the upper extremities. We see blood clots in and around the heart, and we see blood clots in and around the intestines and so forth. So
More often after COVID infection.
yes. So since
Coronavirus.
2019, we have seen just a huge increase in the number of patients that we evaluate for what we think and what we know in some cases, but we think in a lot of cases are COVID-induced hypercoagulable syndromes or blood clots associated with COVID.
A whole new world of
Yeah.
COVID, long COVID, things you think of it as a pneumonia, but it's much more complicated than that.
Yes.
Wow. So